Looking for local? Even more local? CCX Media gives you the option to connect with your community on multiple levels. CCX Create welcomes you, community residents, to connect and experience television in an exciting way. The free TV classes we offer will have you on your way to creating TV, and our wide variety of content can be watched at home or on the go. Connect to what's happening in your community. Visit ccxmedia.org.
Welcome to another program in our series, Freethinking Forum. My name is Bill Weir. I'm the producer and host, and I'm delighted to have with me today Sue Abderholden, the longtime executive director of NAMI Minnesota.
Thanks for inviting me today.
Sue, thank you for joining us. And you're here to answer questions about mental health and illness here in Minnesota today. Mm-hmm. And I know I've seen you in the film that recounts 40 years of progress in dealing with mental health here in Minnesota. Would you like to say anything in introducing?
Well, we developed the video because we were celebrating NAMI's 40th anniversary. And so we did a lot of things during the last fiscal year, including I visited 40 cities in Minnesota in a 3-month span to make sure that we had our fingers on the pulse of what was happening in Minnesota.
Great. So let's see the film now.
I think back to when my father had his first episode. We didn't know what it was. I didn't know what it was. They said he just went mad. That was the term that they used back then.
I felt isolated. I felt like no one understood what I was going through, and I wasn't even sure I understood it.
They kicked him out of law school because of his disability. That broke his heart.
They said, Terry, you're paranoid schizophrenic. The media adds the stigma, newspapers, TV, whatever.
It was an invisible population as a result of stigma, and then as a result of the state hospitals.
It's mommy's fault or daddy's fault.
I mentioned the word schizophrenia, and he actually stepped back from me, like I was contaminated.
I remember as a young child, my grandmother asking me not to tell the neighbors what's wrong with my mom.
In order to figure out where you're going in the future, it's really important to understand your past.
And everybody at NAMI, every single person has a big story to tell.
If you don't do anything to change things or help, nothing gets done.
The system really was locked into a belief system that mentally ill people could not function and excel and get better in the community. They were saying this and they believed this, but at the same time, they were closing state hospitals.
We needed to erase a lot of the stigma that was going on about mentally ill people.
From the early days, NAMI's movement involved the people with mental illnesses, their family members, and the providers in the community. So it really was a coalition.
There was a lot of energy. Office was this tiny little office. So when you would get a lot of people in that office, it could get kind of hectic.
We had a meeting and we wrote legislation.
It also was like grassroots. The bus tour with Al Quee was like a grassroots idea.
We asked him if he'd be willing to spend a day in the life of a person with mental illness. He started by being discharged from Ramsey County Hospital. went to a boarding home, and then went to Apollo Care Center, and there might have been a couple other stops. It really elevated the conversation in a big way. We really became empowered. Many times these legislators had never heard this story about someone in their own community and how they had suffered or their family member had suffered.
We need to end the discrimination in our courts. We need to end the discrimination in our workplace. We need to end the discrimination in our schools. We need to end the discrimination in our country, and I am convinced together we can. Thank you very much.
I remember Wellstone stomping around, and he was our champion at the time.
He also had a brother who had schizophrenia. Wellstone knew what schizophrenia was. He knew the impact it had on people and on families.
My sister was diagnosed with paranoid schizophrenia. And I really didn't understand, and my mom realized and insisted that I needed sibling support. I tended to expect that she could do more. She could get out of that bed and go to church. She could do things like I could, and I think the sibling support groups were just invaluable to me.
Our son was about 18 when he was diagnosed with schizophrenia.
We were in the midst of much questioning and need for support.
First time I really got involved and went to a NAMI meeting, I left there literally feeling like somebody wrapped their arms around me and said, "Sue, it's going to be okay. We get it. We understand." And they did, and they do.
I guess I see the process of recovering from mental illness a very long process, something that takes lots of time.
As I integrated into the family of NAMI Minnesota, I begin to appreciate how common our problems were and how misunderstood they were by the general public.
I think in my community, in the African American community, a lot of times we're asked to pray about it or to just be stronger. And in a situation where someone has a mental illness, it's really important for them to be able to seek treatment, but then also have the support of their community.
The one memory that sticks with me from the class, the Harley guy. He had the Harley shirt on, and he was a great big burly guy. He had a son who was living with mental illness. And he just sat down and cried. You could just see like a load came off his shoulders, because all the time he thought that the problems his son was having were because he had not been a good parent. And he realized that that wasn't the issue.
When they hear stories, they begin to identify.
It started out with just depression, and then depression got worse.
We just want to normalize it. I think if people refuse to talk about it, or they want to talk anonymously, they buy into the discrimination that goes on with this illness.
I was living with the diagnosis of major depression when in fact I was living with bipolar.
Speaking before 4,000 people was actually quite a thrill. Well, I'm myself transgender. There really is a lot of invisibility behind my identity, and being able to be there in front of a crowd and share my story helps me feel that I have a voice in a world where often it's hard to know where to speak and who it's safe to speak to.
Through our classes, through our support groups, they find that they're not alone, they find that they're really part of a movement, and that really helps them take that next step to be advocates.
NAMI Minnesota has an unusually strong influence at the state capitol. And it's because of committed volunteers who spend endless hours.
I don't think I'd ever set foot inside the Capitol until I got really involved. I fell in love with the whole process. I thought, oh my gosh, this is finally one way I can really see that I can make a difference, not only for Joel, for our son, but also for all people with mental illness. We called it the dream legislation. We put down everything on a piece of paper that we thought we might want, and we got a whole bunch of it. I mean, it was unbelievable.
Nobody would talk about it before, but now when they hear something from NAMI, they know these people know what they're talking about, and we better sit down and listen.
I think they've changed the attitudes about mental illness.
NAMI owes what it is today to the volunteers.
I'm very hopeful for the future. I'm very hopeful. I think we've made huge strides.
A movement, by definition, is a lot of people. And that's what we've seen all across the state and all these 40 years. My hope is that more people join our movement and they stay in it for the long haul.
If I could be of any help to them, I would, but I can't even get to a meeting anymore. So I have to depend on this generation to stay with it and get busy.
This is a human rights movement. This is a civil rights movement.
Advocate, legislate, educate. Do those things that we as individuals can do, but we're much, much stronger in doing together.
Wow. What a great film.
It really is very moving, frankly.
Yes.
To learn about the progress and the importance of someone, just a few people raising their voices, especially in the beginning.
Yes. And I think it helps us understand why Minnesota is out in front of many other states.
There's a story about the very beginning of NAMI. It was actually a group of women, which is why we call them the NAMI mommies, right? Because it was moms who came forward.
Yeah.
And they were closing Hastings State Hospital for a number of different reasons. But they were going to take that money and put it into other state hospitals. And these moms came together and they said, no, if you're going to close down that state hospital, you need to take those funds and move it into the community to support people as they transition back to their homes.
Community mental health services.
Community mental health services. And so they went to the Capitol, they had never done it before, and they actually passed the first legislation. And one of the legislators was quoted in one of the major papers, and he said, we'll do anything, just call off the mothers.
Call off the mothers.
So that is my rallying cry,
They're-
call off the mothers.
They're that persistent.
They're that persistent, yeah, absolutely, yeah.
And the mother of my 4 children, I think, was one of those. and Sue, it's just so impressive. You have seen so many changes over your 16 years of service with NAMI, and you probably knew about NAMI even before that, I trust.
Yes, I did.
And what are some of the, as you see it, the major changes?
I think a big one is change in public attitudes. You know, when you look at, creating change, you have to change attitudes and laws.
Right.
And the attitudes have really changed. When I first came to NAMI, people didn't talk about having it or that a family member had it. It was really still a pretty deep, dark secret. But we are seeing more and more people share their story now, which is really helpful. We have, famous people sharing their stories. We have everyday citizens sharing their stories. And every time someone shares their story and they look like you, it breaks down that wall of stigma and discrimination, because you can look and say, oh, that's someone that's like me. It can happen to anyone. So I think the attitudinal change is great. We still have some work to do in terms of how we treat people in our community. So for example, if you ask someone with a serious mental illness when they were hospitalized if they've ever received a get well card, most of them will say no. And so we're not sending notes saying we're thinking about you.
So they need get well cards along with everyone else. Too.
They certainly do. And families need hot dishes. This is a no hot dish illness. Hot dish is a word I learned when I came to Minnesota. People need meals brought to them.
Oh,
and
yeah.
Families don't get that kind of community support.
Really?
No. We really call it a no hot dish illness. So we need to provide that support as you would for anyone, for any kind of healthcare condition.
Whether it's cancer or
heart disease
or mental illness.
Yep.
They need the help and attention.
Absolutely.
Neighborliness.
And then the other part is language. If you look at every civil and human rights movement, language has been a huge part of it. The women's movement, certainly we stopped calling, adult women girls in the workplace, right? We recognized that they were, full adults and we should call them women. In the developmental disability movement, we don't use the R word anymore for retarded, right? We talk about people with intellectual disabilities. And what we have not seen is the transformation of language in the mental health movement.
Really?
Well, think about how many times you hear the word crazy in one day.
I don't.
You hear it, you really hear it a lot. It's part of the lexicon. If you really listen, you will hear it. And we don't have slang words, crazy, nuts, psycho. We don't have slang words for any other healthcare condition. Not for diabetes, not for heart disease, not for cancer. And so for a young person who is developing a mental illness, experiencing those symptoms, when they hear the word crazy all over the place, they're afraid to come forward.
Yeah, what should we say when we hear that coming from somebody else?
I usually say that's not a word I would use.
And nor should you.
You can think about another word. Someone is driving me up the wall, or someone is, it's a difficult situation or things like that, but we really need to think about the impact of language on how people with mental illness feel about themselves.
Yes.
So that's kind of the attitudinal thing. For the public.
And even I've heard about person first language.
Yes.
Person with mental illness. Or
we usually think about it as either with a mental illness or with mental illnesses, plural, because they're not all alike. Depression is different than anxiety, is different than bipolar disorder, is different than schizophrenia.
Right.
So just letting people know there are a variety of illnesses and they're not all the same.
That's important.
Now the laws part is also, I think, really important, that we have made some great progress there. But of course, we still have, frankly, a long way to go.
And Minnesota seemed to have, from the 40 years film, made progress even before the federal government acted. And
Absolutely.
I suppose it was an inspiration maybe to the federal Congress to take action.
Well, hard to know how much Congress really looks at what is happening in the states. But, I think there are certain things.
Well, they heard about it from Senator Wellstone.
Yes, certainly in terms of working on parity. Senator Franken has worked with us on making sure that children in schools have access to treatment and things like that. So there are some takeoffs, frankly, from some of the things we're doing in Minnesota, but there is a lot left to be done.
So are there other main issues today that you would want to point out?
So going into the next legislative session, we have a couple of big things. One is actually reducing and putting some constraints around the use of seclusion or solitary confinement in our prisons.
Oh, solitary confinement is so destructive, isn't it?
It's extremely destructive. The UN says that anything over 14 days is actually torture.
Yeah.
And we have had people in Minnesota prisons, including living with a mental illness, be in there for a year.
Oh, no.
Yes. And so the Minneapolis Star-Tribune did a big series about this not quite a year ago, really showing how often it's used in Minnesota, what it's like, what are the outcomes and things like that. So we had a bill last session, it passed the House but not the Senate, that really looked at not eliminating it, because we understand they need it for safety issues, but making sure that there's oversight, making sure there's some basic standards, making sure that people aren't released directly from solitary confinement to the community, which many are, which is not a safe thing.
That's deadly,
it's
I think.
horrible, absolutely. So that's a big issue for us. We want to make sure that we are treating people with respect, even if they're in prison. You know, we don't need to make things worse. If we want to talk about public safety, we want people to come out and be well. We don't want to release them when they're not doing well.
Exactly. Now, do you need more sponsors in the Senate, or?
We have authors. We just need to get the committee to hear the bill and try to move it forward.
Which committee will it start with?
It's the Judiciary Committee.
Oh, I know the chairman.
Yes,
I'll be
Senator
speaking with
Limmer,
him.
yes, is the chair, yes.
So, and the ranking member.
Yes.
He's important too. And we've recently seen a story about school teachers here in Minnesota feeling that the stress of working in the schools with the children in their classes and is threatening to drive them into mental illness. Do you have a comment? Does NAMI have any resources to help the schools deal with that stress?
Well, I think there's a couple of things going on. One is that there's a lot of expectations put onto teachers in terms of tests, right?
Trust.
You know, tests. So kids need to
tests.
be, kids need to be testing well. You know, they're teaching to the tests instead of using some of their creativity. One of the things that we did quite a few years ago is we were actually the first state in the country to require teachers to have training, continuing education on the early warning signs of mental illness in children.
Oh, good.
And last year we actually added 1 hour of suicide prevention. And we think that actually helps the teachers because they need to know that some of the behaviors that they're seeing in the classroom are not behaviors, they're really symptoms. And what every teacher wants is to help a child do well. Well, if you're treating it as a behavior, you're not really helping that child get through that. So they need to see it as a symptom and do it a little differently.
And maybe do a referral.
Exactly. But then learn some strategies in terms of accommodations in the classroom to really help that child. And the other thing is we're needing to see a lot more, especially in high poverty schools, is trauma informed. So you have children who have been in very high poverty situations, perhaps they witnessed domestic violence or some other violence in their community. They get kind of PTSD just like a returning soldier.
The post-traumatic?
Absolutely.
Stress syndrome?
Exactly. And so what these kids need is a trauma-informed school so that they understand what's going on. So a child who may be raising a fuss in a classroom, perhaps something happened the night before.
Maybe acting out.
Because, you know, little kids don't know, you know, they can't express their feelings
very well. How do I deal with the feelings?
Yeah, and they don't know how to deal with this. So trauma-informed schools has also been a way to help using things like meditation and mindfulness training in the classrooms, social emotional learning. We have a lot of children in Minnesota that are suspended between grades kindergarten and 3rd grade.
Really?
Now, suspending children that young does not teach them anything.
Doesn't make sense.
It does not make sense. And so we need to address that differently.
Yeah, solving the problem differently than suspending.
But making sure that the teachers have the tools to do that.
Yeah. And maybe it's more than the teacher of that particular class. Maybe the school itself that may need to have more resources.
Right. One thing we found is there's a practice called Positive Behavior Interventions and Supports, PBIS, and what they look at is trying to create a culture in the school where everyone knows the rules, adults too, and students, so that, you know, there's no it's really clear what the expectations are, which also really helps kids. And then if some kids need a little bit more help, then you have your school support personnel, your social workers and things like that. And then some kids really need that clinical level. But what they found is, because they really have to collect data, they can discover that some of the most chaotic times are right before lunch. And so maybe there's something different you need to do at lunchtime.
Maybe an earlier lunch.
An earlier lunch, you know, maybe it's a transition from one classroom to another. And so really trying to find where those trouble spots are and addressing them. And they found that to be very helpful.
Yeah. Well, I've been aware about the need for the right nutrients at the right time. And are there also problems with the nutrients that are in the schools?
Well, part of it's, you know, some kids really
Much
need
sugar?
Well, they need school breakfast and school lunch.
Yeah.
You know, you have some kids that's, you know, they're acting out because, or they're slumping in their chair because they really have not had dinner, they have not had breakfast. And so, you know, it's kind of like Maslow's hierarchy of needs, right? You need to make sure that your stomach is filled before you actually start teaching them.
Yes, that's so important. And so, are there other things the schools can do to help, and parents can do to help ensure that their child is learning in school?
So we have a program in Minnesota called Schooling to Mental Health. It was passed in 2007. Funding went out the door in 2008. And so we're not expecting schools to provide clinical services.
No.
But, you know, mental illness is a childhood illness. Half of all people who, you know, are adults with a mental illness began experiencing symptoms before the age of 14.
Really?
So if we wait till they're adults, we've waited too long.
You need to recognize the symptoms early and be able to treat them so they're not dysfunctional as adults.
Absolutely. But one of the problems, if you're a working parent, right, the average length of treatment is about 20 visits to a therapist. So think about taking off of work once a week for 20 weeks. That is really difficult. It's a huge...
Most employers won't stand for that.
No, they won't. And so what we did instead is we had grant funding that went to a community mental health provider who then co-located in the school.
Oh, they get space in the school.
They get space in the school,
So
but there's a firewall between kind of the education records and the healthcare records.
Yeah.
That provider, because they're a community mental health provider, can bill insurance, Medicaid, private insurance, you know, Minnesota Care. So we have some funding streams for it. The grant pays for children who are uninsured or underinsured, and for things that you can't bill insurance for, collaborating with the teacher, that type of thing. And what we found all these years is that half of the children had never received treatment before, and half of them had a serious mental illness. So you know they weren't doing well in school. We are in about 85% of school districts and a little over 40% of actual school buildings. So we've made some huge inroads. I have to tell you that it is an extremely popular program with parents, with teachers, with principals. There's fewer referrals down to the principal's office. Suspensions go down. There's even been some conjecture that reading scores go up because, you know, if you're not able to concentrate because of the symptoms of depression or anxiety, you're not going to do well in school. And what we want is for every child to succeed. So this can be a barrier. Untreated mental illness can be a barrier to succeeding, and so we want to take care of that and help those kids.
Yeah, but we're wasting our time trying to educate a child who's deeply into depression.
Exactly, yes.
And so we need to treat that depression first.
Yes.
And first of all, recognize it in order to enable the referral to the community mental health service in the school.
Yes.
Not of the school, but in the school.
In the school, yes. Yeah, because we don't think it's not the role of the school to provide clinical treatment.
Right.
But they need to collaborate with providers to make that happen.
Yeah. And I saw a recent investigation by the Star Tribune reporting that a person with a mental health emergency, when taken by police or others to a hospital emergency room, or go on their own, may be kept for days in the emergency room because there's no bed open for psychiatric care anywhere.
This is an issue actually across the country, not just in Minnesota. And the answer is not necessarily build more beds. Because if you think about it, people spend a very tiny percentage of their life in a hospital bed. They spend most of it in the community.
Right.
And so when we really look at the issue, what we know is that people, they start experiencing symptoms. They can't get in to see a mental health professional for 2 or 3 months. And so the symptoms get worse. So now they're thinking we're starting to reach a crisis. Now we have mobile mental health teams, crisis teams in Minnesota, but most people have no idea who they are. And if you call 911, they're not going to refer you to them.
Really?
Yes. And so you don't know, who knows about them, right? You've got to write down the number, and there's 40 numbers in Minnesota. So they could have been diverted then, but they don't know about it. So they go to the emergency room. Now, they could have gone to urgent care, because we all learned about urgent cares, right? Go there instead of the emergency room, but urgent cares don't take care of mental health issues. So the only place they can go is an emergency room. Now, some hospitals actually have psychiatric emergency rooms, which are great because they're quieter, right?
Yeah.
If you have symptoms maybe of schizophrenia, going into a regular emergency room, which is loud, and think about those curtains on that metal rods, it's really disruptive. But a psychiatric emergency room is quiet, it's staffed with mental health practitioners and professionals. It's a much better way to go.
Would Regions?
Regions has a psychiatric emergency
example.
room, yes. Yeah. Now the problem is that someone went to the emergency room because they need help, but they might not actually need hospital level of care.
Right.
Not everyone who's in an emergency room gets admitted. So then it's kind of like, well, they need to go somewhere, but there's nowhere for them to go. And then even if they do need hospital level of care, we have a problem because people who are currently in those hospital beds are waiting for something else. Might be that they're waiting for Anoka Regional Treatment Center, they might be waiting for residential treatment, so they're taking up a bed that they don't need anymore, but they can't move out because there's nothing else anywhere else to go.
Vacancies at the other
at the next step. And then if you go to Anoka Regional Treatment Center, we have a large percentage of people there who also don't need that level of care anymore and are waiting to go into the community.
They could be discharged.
They could be
make
discharged.
Way for others.
Right, if there was somewhere to go. So in one way we have a flow issue. We can't get people through the system to the right level of care because we're backed up. Now,
what level of care is most important to?
I think what we really need are what are called crisis homes.
Crisis homes?
Yep, so they're small, typically under 16 beds so that you can use Medicaid to pay for them. They're more home-like, and people can go there and just kind of, really work on their recovery and go home. It's usually less than 10 days, so much shorter than residential treatment. We need a lot more residential treatment beds where people can be long-term, but we also need more supportive, affordable housing. So a lot of the people at Anoka, they've been gone from their community for several months, so their housing is gone. And so they need housing to leave, but there's none available. So it's, unfortunately, people would love, and legislators would love to say, well, if we just did this one thing, but it doesn't work that way. It's far more complicated.
Well, crisis homes. I don't believe I've heard that term before.
We've had them for a few years. Yeah.
And are there some good examples of crisis homes?
People Incorporated has one, Guild Incorporated, Hennepin County is building, HCMC is building them so that they can get people out of their hospital and emergency rooms. There's, Northern Pine, Duluth, they're really kind of all over the state.
So they're beginning sponsored by hospitals.
Hospitals, community mental health centers, counties coming together. So people see it as a really good, viable alternative. We just need more.
Yeah.
And I think that's really the issue when we look at the mental health system in Minnesota. Some people say we have a broken mental health system. We like to say we never built it.
Yes, it's time to build it.
We never did. We had the institutions, which I had been to every single one of them in the 70s. It's not any place nothing against the people who work there, but that's not a place you would want to live. And we rightly closed them down. And thanks to President Kennedy, we closed many of them down across the country. The problem is that the funding then to actually develop community mental health services, it was there a little bit and then it was taken away, and so it never really realized. And so what we've been trying to do over the last 40 years is really develop that community mental health system So I would say that we know exactly what works, and we have the foundation, but we just don't have them built up enough to actually meet the needs.
But now, let's talk about parity. There is now, in some areas, parity for mental health with physical health problems, equally funded and.
Well, it's not about funding per se. So mental health and substance use disorder parity, we have a federal and a state law. And what it basically says is that if you cover mental health and substance use disorder treatment, you have to cover it the same way. And this is for private insurance, self-insured plans, plans offered on the open market. And there's kind of 3 pillars. So one pillar is that you can't have different out-of-pocket costs. You can't charge different co-payments or deductibles. The second pillar is you can't...
So costing the patient no more...
Correct, than you would for any other healthcare condition. The second one is arbitrary treatment limits. So you can't say, well, you can have as many physical therapy visits as you want, but you're only going to get 3 therapy visits for mental health. It's arbitrary, right. So you can't do that. And the health plans have been pretty good about those first 2. It's the third one that causes the most problem. And when you think about building our mental health system, we need public and private dollars. So if we don't have the private dollars there, it's a problem. And so the third one is what they call non-quantitative treatment limits, which means you have to look at basically things that you can't count, but wanting to make sure that they're the same.
Such as?
So one example would be if you get a new knee or hip, your private insurance will pay for rehab in a nursing home.
Yeah.
But if you're leaving the hospital because you have schizophrenia or bipolar disorder and you need rehab, they won't pay for that.
Why?
They just don't.
They don't see the need.
Well, we think the law requires that of them. And so one of the things we've been working with the Minnesota Department of Commerce and Health is a bill which was introduced last session. We hope to get it passed in 2018, is to actually enforce the law in Minnesota and to look at plans before they go on the market to make sure they're actually following parity.
How do we find that bill it's been introduced?
It's been introduced, yes. You could actually probably find it on the NAMI website, and we would have a link to it.
Just go to NAMI.
Helps, HELPS, helps.org, yeah.
Good. And certainly NAMI does help.
Yes. But I think it's an important piece, and I think, one of the reasons that Senator Wellstone pushed it, and I think it's also important to remember it's called the the Wellstone-Domenici Mental Health Parity Act, and you had someone who is a far left Democrat and a far right Republican coming together for this legislation because they both had family members that were really impacted by the lack of mental health parity. And frankly, a lot of families went bankrupt trying to pay for that mental health care. So it really is kind of that last kind of bit of discrimination against people with mental illness that we need to eliminate.
Yeah, so we need to make sure that the rehab needed for mental health, the non-quantitative
yes, treatment limits would be
is remedied in 2018.
Correct. Yep.
So we'll talk to our senators and representatives about that. But did you want to say anything more about mental health parity?
One other part of a non-quantitative treatment limit is what we call step therapy under medication, which means that even if your psychiatrist thinks there's one medication that would be best, that would really help, they might have to do what's called step therapy, which is to offer you the oldest, cheapest medication first. And once you fail on it, then you can go to the next one. And so...
just asking for people to fail.
Exactly. But it gets done with mental health medications more than others. And so that would be another thing that we would be able to look at under the law.
You can't have the medication that works because you have to try the one that doesn't work to prove it.
Exactly. I know. It's not how we treat, again, it's usually not how we treat other mental illnesses. And because of genetics, if If you had a dad, for example, that had depression, and he, after many years, found the right medications, combinations and dosages that worked, if he then had a son or a daughter with depression, you would want to try those medications first because the likelihood of them working is good, again, because of genetics. But that son or daughter might not be able to do that, and we don't want to waste time when it comes to mental illness.
No, and we are wasting time when the step medication is required. Steps from the worst, the least likely to help, to finally get up to the one most likely to help.
Exactly, and that can take years.
We've heard a lot about possible changes in Medicaid and the ACA, which stands for
Affordable Care Act.
Affordable Care Act, often called Obamacare. And there's something about block granting. What's the importance of this?
So what Congress was looking at was kind of destroying some of the things that actually made sure that more people got treatment than ever before under a mental health system. So whatever people think about the Affordable Care Act, there were a couple provisions that really helped people with mental illness. The first was you could stay under your parents' plan until age 26. So most mental illnesses occur by the age of 26, and that used to be the highest uninsured rate group. So we want to make sure that they have insurance. The second thing was that they required any plans that were offered in the exchange to actually cover mental health and substance use disorder treatment and follow parity. Mental health and substance use disorder treatment were considered one of the essential benefits, so every plan had to offer it. So that was a good thing. The other thing was that they did what was called Medicaid expansion. And so you could now, as a single adult, get on Medicaid if you just didn't have much money. Prior to this, you had to actually prove that you were disabled in order to get Medicaid, or you had to be married with, or have children. So I want you to think about a 22-year-old develops schizophrenia, and they're told that the only way they can get the insurance coverage they need to get the treatment that they need, because remember, private insurance doesn't cover all the different treatments that are available under Medicaid, you would have to go to the Social Security Administration and say, I will never work again.
Really?
That is the worst thing that you could possibly say to any young adult.
Right.
So now they can go on Medicaid expansion. And we've had over 50,000 people in Minnesota be able to access treatment, mental health and substance use disorder treatment, because of Medicaid expansion.
So they can continue working and yet get help.
And get help, exactly. So what the federal government, what Congress was thinking about doing is kind of taking some of those things away under...
Why?
Well, I can't explain it. But the other thing they were talking about doing with Medicaid as a whole is, right now, the federal government matches what we spend in Minnesota on Medicaid for health care and mental health care. Instead, they would say, we're going to look at what you spent in 2016, however many dollars those are. So let's say it's, $10 billion. We're going to take those $10 billion, and that's all you're going to get in the future, and we're going to get rid of all the strings that are attached to it, and you just have to fund your services. Now, on the one hand, states might say, well, that's great. We can just create the services and fund what we need. But the problem with the mental health system is that we're still growing it. So we have new residential treatment beds coming online, new types of community services coming online. Those costs, which will start happening in 2018 and 2019 and 20, won't be included in those 2016 dollars.
So that block grant is not the way to go.
It is not the way to go. And frankly, one of the reasons we never developed the mental health system is because we depended on block grants. During every single recession, the first thing that is cut is block grants. Even in Minnesota, under our, not even the federal government, in Minnesota, when we had the recession, around 2010, 29, around there, we lost over $50 million.
$50 million?
In grant monies, state dollars, for mental health.
Wow.
So we would rather that you pay for health care dollar by dollar like we do for everything else and not make it a block grant.
Yeah, block granting is not the way to go.
It is not the way to go.
Because it doesn't allow for the fact that we're having to expand the mental health system.
Mm-hmm.
And so one of the things I know many people are concerned about is how can we better address children's mental health? We've talked a little bit about the schools,
Mm-hmm.
but there's a larger issue. What do you say to how can we better address children's mental health?
Well, I think we have to start looking at a couple things. You know, we see mental health issues starting to develop very young. So we have early childhood mental health programs that can work with child care providers to really support those kids to help them learn how to regulate themselves and, you know, address trauma and things like that. And when we're looking at teenagers, we really need to look at the impact of social media and bullying. Kids need to be disconnected from their smartphones, as hard as that might be. When I was in school, in high school or elementary school, if we were bullied, then we went home, right? We had a respite, we had a break, but you don't get that break anymore. Bullying is 24/7 because it's through your smartphones, whether it's through texting or Instagram or Facebook or whatever it might be. It is constant, and kids are really not dealing with that very well.
Really?
And it's understandable. So bullying is a much bigger thing than it was when we were growing up for that very reason. The other thing is there's starting to be new studies about kids who, including college students, who are on social media a lot. It really does hurt them in terms of developing depression and anxiety. And part of that is because you're kind of in a constant state of comparing yourself to something else. Those folks on Facebook are having, those people I know are having a lot more fun than I am. They're looking much better, than I am. And you start doing those comparisons, and it can really make it difficult. So we need to get kids to unplug. We need to, make sure that they're getting, exercise, taking walks around their neighborhood, going to the park, whatever it might be. Not high stress sports, but just regular kinds of activities. And we need to look at what they're eating. We need to make sure that they're having a nutritious diet, not filled with junk food and things like that.
Yes, I've been talking with a nutritionist on a mental health committee at our congregation. It was working on make it okay. We not looking down or bullying or shying away from people that may have a mental health problem. Try to relate to them and help them get the care they need through the ministry of the congregation and help them feel like they're still part of the community.
Being connected to others is really important. Sometimes when we talk about treatment for mental illness, people immediately jump to medication.
Yeah.
But that is only one part of it. People often need therapy so that you're looking at things in a different way. You're not doing negative self-talk, things like that. You're developing coping strategies. We know that exercise and nutrition play a role, being connected to others, spirituality, having a reason to get up in the morning. Most people with a serious mental illness are unemployed, and that is a recipe for disaster. We all need a reason to get up in the morning.
To feel I can do something worthwhile.
Well, everyone brings something to the table. Everybody has a gift to share. And if we don't make sure that we're creating space for people to share their gifts, we're really leaving a lot of people behind.
One of my daughters is an art therapist, helping people who have some kind of mental illness express themselves through some kind of art. And that helps, I think, in the talk therapy as well.
Absolutely.
As in creating more self-understanding that will help them get well.
Well, I certainly applaud her work. I think it's really important.
Yeah, she's worked on this for many years, serving as president of the Minnesota Art Therapy Association, and finally going full-time with the university health, working with young people.
Good for her.
And we've talked, was there something that we needed to learn about early childhood?
A lot of it is related to trauma, frankly, when we look at early childhood. And we've had a lot of children who have been, frankly, kicked out of childcare. And
Really?
Yes, it's a huge problem.
Because they're acting out?
Because they're acting out, because they can't really explain what's happening to them. And so early childhood professionals, and they have a certification, they will go in and work with the teachers, with the child, with the family to really help them, get that child back on the right track, which again is very, very important. We're learning so much in a way about, how do we do early intervention and support. There's a fairly new program developed through the National Institute of Mental Health. We have a couple of programs here in Minnesota, but we need more, and it's around schizophrenia.
What's it called?
First Psychotic Episode Programs.
First Psychotic Episode Program.
Yep, FEP. And what we found is that, schizophrenia can be one of the most disabling conditions worldwide.
Oh, yes.
And we weren't really doing anything.
Yeah.
Someone developed the symptoms, maybe they ended up in an emergency room, maybe they were hospitalized, maybe they went to Anoka, put on some medication and sent home. And that's all we did. And to me, it was kind of like going to your doctor says you have cancer, and they say, come back when you hit stage 4.
Oh, no.
We
that
wouldn't,
unheard of.
Well, but that's what we did with schizophrenia. We wouldn't do anything intensive till someone had been hospitalized multitude of times. So what this program does is it tries to really change that and provide more intensive services. First, they try to reach that young person early. Right now, it's an average of 74 weeks before a young person seeks treatment for schizophrenia.
Really? Too long.
Too long. So they try to reach them early. They're not hospitalized yet. You can put them on a low dose of antipsychotics, so there's not as much, side effects. They put them in therapy. They put them in a support group with other young people so they know they're not alone. They educate them about the illness. They do cognitive remediation on the computer. They educate the families, support the families. But the most important person on that team is a person who helps them get back to school or work, so the trajectory of their life doesn't change much.
Yeah.
And it's found to be extremely effective. So we're really offering hope for these young people. Unfortunately, we need about 8 programs in Minnesota. We only have 3. But it's...
Well, that's the kind of thing I know a lot of our viewers would want to help with.
Yes, it's kind of a no-brainer, frankly.
Where do we have them?
So 2 are with University Fairview, and 1 is at HCMC.
Both in Minneapolis?
Both, yeah, all 3. Actually, one of the University Fairview ones is in St. Louis Park.
Yeah. Oh, at Methodist?
No, it's outpatient.
Oh.
So these are outpatient programs. And we do have a booklet on the NAMI website on First Episode that really can help families understand what to do, even if they can't get into the program, things that they can fight for to really help their loved one.
Now we've got less than 5 minutes left.
Okay.
This hour has gone very fast.
Yes.
And what would be most productive in these last few minutes to add?
Well, I'd like to add a couple things. One is for people to know that NAMI is a resource. So it's not like in your high school health class you learned about how to help someone with schizophrenia or depression or anything like that. So we offer free education classes for family members so they really know how to help their loved one.
That's so important.
It's very important. We don't want them to feel guilty. We want to help them know how to de-escalate a situation, how to help someone. We also have peer-led support groups. There is nothing like going to talk to somebody who's been there, right?
Yeah.
So the support groups are really important, and we now have web-based ones that you can actually access through your smartphone.
Oh, they can communicate
that way, which is
over
helpful.
The internet.
If you don't have transportation, it's very helpful.
Yes.
We also do a lot around suicide prevention because the suicide rate in Minnesota is growing, and including across the country, especially middle-aged white men. And so we do a lot of work in that area. And we also do a class for high school students called Ending the Silence.
Ending the Silence.
We want them to understand what those symptoms are so they can identify them in themselves or in their friends and know what to do, what action to take.
So how do schools sign up for this?
they can just contact our office, and we can't do it next week. We have to schedule them out a little bit because we have such a huge request for them, but we will come into the school and provide that.
What's the time needed to get that
It's a
set
1
up?
hour. So 1 hour health class. If people can give us a couple of weeks to arrange it, that's the best.
Good. So they're not committing a huge block of time.
No.
And they can get help within 12 weeks or so.
Absolutely. Yes.
Oh, this has been so helpful. We don't have to end right this minute. We have a couple more. What else would you like to add?
We do have a workforce shortage in Minnesota.
Yes, we do.
And I just really like to encourage people, if you have, whether you're a high school student or, college, have an inclination to help people, there are lots of job openings in the mental health field. And it is a very rewarding profession. And again, we need people to go into those jobs, and particularly people from culturally specific communities, diverse communities, so that we have more culturally competent care that can be provided as well.
That's so important.
It's very important.
People from other countries that may not be able to relate to the typical Minnesotan or the long-established Minnesotan.
Well, and some people might not understand the impact of racism and implicit bias on someone's mental health, and so might not view it the same way. So again, just really encourage people. There are a lot of jobs out there in the mental health field, and we need them.
For the full spectrum of people.
The full spectrum, not just psychiatrists.
Yeah.
I want to tell you a funny story. So, people are always saying, we need to study the mental health system. We need to have work groups and figure out what to do. I read a report that said, here's what we need to do. We need to have a community mental health center for every 50,000 people. We need to have an inpatient psych unit in every community hospital. We need to have mental health professionals in the school. We need to have emergency mental health services, and we need to address workforce shortages, including child psychiatrists. Do you know who proposed that?
Who?
President Eisenhower.
Wow, good for him.
But how
we
long?
didn't pay attention.
Exactly. So we have known for a very, very long time exactly what we needed to do. And so we just need the willpower. And so if you're out there and you live with a mental illness or have a family member, I want to encourage you to join our movement. Help us really continue to, go to the legislature, raise awareness, and really create the change that we want to see.
I'm looking forward to learning how I can help.
Great. Wonderful. Thanks again for having me on.
And thank you for tuning in.